We do have one question so far from Naples, and the question is, what phase is Nivolamap in and when might it be commercially available?
That's a great question. So there was a phase 3 study that's now completed accrual. It was in the VEGF targeted therapy refractory setting, so second line setting plus second or third line, and patients were randomized either to Nivolamap or everolimus. And so that's completed accrual and the data are maturing. I think it should come out, the data results, I'm not exactly sure when they expect them out, at least a year is my understanding. I don't know if you have a little bit more insider knowledge there.
That sounds right.
Yeah. In terms of other things, so that's the monotherapy data. There are other trials that are being proposed and developed. I think that they mentioned at ASCO, so it's not, I think, a secret, but I know BMS is certainly thinking about moving it to the frontline setting and whether it would be good to combine it based on the data with the combination of Nivolamap plus the CTLA-4 antibody ipilimumab, where they saw some significant synergy with response rates, at least, whether that'll be a good next step for this drug, combining it with ipilimumab.
Lauren, do you think that the responders, was there any indication that the responders on the anti-PD-1 trials exhibited any of the, were more likely to exhibit any of the autoimmune effects? Yeah,
that's a great question. I think we all wondered if the patient had that pneumonitis, would they do better? My discussions with the companies have shown that I don't think they have noticed that patients with the autoimmune effects are the ones that necessarily have the better responses. The autoimmune effects don't always necessarily happen right away either. But I don't know if you've heard anything different.
No, I don't think that there has been much discussion about that, and that's one of the reasons that I asked. And another question that occurred to me when you were presenting the Nivolamap data and some of the other anti-PD-1 data was just that, you know, this seems to be a milder therapy, and so that would make patients and clinicians much more enthusiastic about offering it, but it also seems to be a kind of a continuous treatment, whereas the high-dose IL-2 treatments were given for a very short period of time, and then patients, you know, are off of it. And so they might be having a lot of side effects initially, but then they get to kind of walk away from the treatment. So what's your perspective on the anti-PD-1 inhibitors in regard to that?
Yeah, no, that's a great question. You know, I think part of the reason that high-dose IL-2 is given like that is that you can only give so much of it and you have to let the patient recover. With the PD-1 agents, we don't know yet when we can stop, right? So we know that patients in the early phase trials, after a certain amount of time, it was I think 96 weeks in the phase 1 study, after they had to come off the therapy, even if they were responding. That was part of the trial. And we know from that group of patients, as well as other patients that had to stop even though they were responding for tolerability or other reasons, that a certain degree of them actually had continued responses. And there was a handful of patients that actually had an even, you know, continued decrease in their tumors off therapy, sort of making, you know, supporting the idea of induction of the immune system and the potential for a memory response, which is certainly unattainable with our targeted therapies. So I think we have no data really to tell us when can we stop this. We know with chemotherapy is the same thing, that we give it for a short period of time, but eventually we have to give the patient a break, even if they're responding, because of the toxicity. With the PD-1 agents, they seem to be more tolerable, so we kind of keep going. And I think first of all, we're going to need to prove that they truly are effective and get them approved, FDA approved, and then we can start to say, can we give people breaks? Could we do sort of intermittent versus continuous PD-1 blockade?
Absolutely. Yeah. And a few other questions have come in. One of them is, could you comment on adjuvant treatment? And I'm presuming that the questioner is asking about both the VEGF tyrosine kinase inhibitors as well as the mTOR inhibitors as well as the newer agents such as the anti-PD-1 therapy?
Sure. So we know, taking it all the way back to the interferon alpha and IL-2 era, that we know there were at least 7 or so, unfortunately, failed adjuvant trials that did not show a benefit to giving those agents after nephrectomy in order to try to decrease the risk that the tumor recurs. Now we have, and I'll let you weigh in too, Dr. Haas is the PI of the large ASSURE trial, which actually is studying whether giving a year of adjuvant sunitinib versus sorafenib versus placebo is actually going to show a decrease in recurrence-free survival in our patients who have had nephrectomy, but no obvious metastatic disease. There have been multiple other studies, including an adjuvant pazopanib trial, several other adjuvant sorafenib and sunitinib trials, and at least one ongoing exitinib trial, all asking this very question of whether we should be moving these targeted therapies from the metastatic setting earlier to the potentially cured stage, non-metastatic stage, but especially in those patients with T3 and T4 tumors that we are concerned have such a high risk of the disease coming back. And now, oh, sorry, go ahead.
And now, and of course, the Everest study, which is a everolimus versus placebo, is ongoing. And I know that there are plans to move the anti-PD-1 agents also into the adjuvant setting as a future trial of great interest. And I think that the giving treatment in the adjuvant setting is a challenge, both on the side of the clinicians and also on the side of the patients. It's a big commitment to a patient whose disease is completely resected and has no side effects, and do they want to put up with side effects? How do we pick the best populations of patients to study? Do we pick the most high-risk patients? Do we treat these patients for a whole year of therapy? Do we give them a more modified treatment? Do we give treatment before they actually have their renal tumors resected? That's especially relevant with the anti-PD-1 therapy. And are there biomarkers that would soon be available based on some of the data that Dr. Chouari is going to be discussing that might indeed be useful in the future to help design these trials going forward? So currently there's no outcome data as far as any of the most recent current adjuvant trials, but I expect that we'll see that information come in relatively soon. Lauren, I wanted to mention that there were a couple of other questions that have come in. Another one is, what do you think is the best treatment option these days for chromophobe histology in a patient with slow progression over a year and asymptomatic?
That's a great question. As I just struggled with that in the clinic, but in a more aggressive, unfortunate chromophobe patient, metastatic disease to the liver. I think chromophobe is it's more heterogeneous than we give it credit for. I think, a lot of times we say, oh, it's the better prognosis histology. It tends to be more clinically indolent, or it just, is more locally advanced. And it's definitely one of the histologies where I will actually do metastectomy after metastectomy in a patient that just sort of every now and then pops up with one node or a different site in the nephrectomy bed, or even a pulmonary lesion. But it is a hard call of when to pull the trigger to start an agent that may not be that effective. I think these are ideal patients where if you have access to a mutation profiling system like we have at Dana-Farber called Profile, there are other things like Foundation Medicine where if you can sort of get an idea of what their tumor's mutation looks like, it's great. We know that we don't know exactly how to use that, but if you see upregulation in one of the mTOR pathway genes, it might make me push to try an mTOR first over a TKI. I think either way, you'll probably try both in that patient, and so it's just a decision of which to try. It also wouldn't be wrong if it's very slowly progressive indolent disease, whether to watch them. I know Brian Rinne and colleagues are doing those very trials of saying, when can we sort of watch for the metastatic disease for a while versus, and sort of have a delayed start to the targeted therapies.
Yes, and one of the challenges is that these are very rare tumors, and it's actually very rare for a patient with a chromophobe renal cell carcinoma to develop metastatic disease. So that's another challenge that we have to face. There was also a question in regard to whether we're getting most of our information from, as far as moving forward with clinical trials and with the field, from industry, and are we relying more on industry or data from institutions? And I really think you can comment on this as well, but I believe that a lot of the information that we're reporting here is not just from pharma, it's also from, in fact, the important prognostic criteria. The Heng criteria is based on participation from multiple institutions.
Yeah, no, I agree. I mean, I think at the level of most of the trials we've discussed had a very heavy academic input in terms of the participation and trial design early on. I do think it is, you know, a concern as we all try to sort of design clinical trials, and you know, I don't know that there's always a right answer, and most of us think that we want things a certain way, and we know that industry has to have sometimes a little bit different mindset in terms of thinking of other, not always completely the pure science of it all, but sometimes the financial implications and all of that. But
speaking of that, here's another question for you from me. You have a patient who has very limited financial resources. They present with some poor risk features, perhaps, but perhaps are more in the intermediate risk category. In other words, they're anemic, they have a high calcium. How might you choose which of the therapies to treat this patient with?
Yeah. Again, I don't think we have great data in poor risk disease, but we're still going to try to use what we know. And if I don't have a good clinical trial that could potentially delay or, you know, take away some of the financial burden of some of these high co-pays with our targeted therapies, I'll think about if we don't have any financial assistance programs to get them a drug. We were talking about how, you know, do you choose the IV drug that you can give in the clinic, and maybe you know, sort of take away that whole issue of the copay. And so I think as we choose these drugs for our patients, when we know that one is not necessarily better than the other, that it's not unreasonable to choose the IV drug for the patient, whether it be temsirolimus for the mTOR inhibitor or bevacizumab for if you want to try VEGF inhibition. I tend to I tend to choose everolimus over temsirolimus generally because it doesn't tie the patient to coming to the clinic weekly. But sometimes that's not a bad thing, especially when you have a sick patient that could use the extra eyes on.
And a patient who has congestive heart failure, might you choose a different tyrosine kinase inhibitor? Yeah,
so in terms of, now that we have more definitive data that at least the sunitinib is likely superior, though it was a non-inferiority trial, likely more effective than everolimus in the first-line setting. I will generally reach for a TKI over an mTOR inhibitor. However, there are certain features like if someone has significant congestive heart failure, and we know that sunitinib has anywhere from a 5% to upwards of 15% incidence of worsening or having a new congestive heart failure, makes me a little bit nervous to use that drug. And if you look across, we did a series when I was at Stanford of looking across the other agents. It's not just, sunitinib gets the worst rap for it, but all of the agents have some degree of cardiovascular toxicity, all of the VEGF targeted therapies. The mTOR targeted therapies have more issues with hyperglycemia. Pneumonitis is a real issue. So, but for congestive heart failure patients that are significantly symptomatic or have a chance of worsening, I'll probably reach for an mTOR inhibitor first.
So, Lauren, there are two other questions, and then we may have to curtail that. One was, do you think there'll be certain differentiations among the anti-PD-1, anti-PD-1L ligand and the anti-CTLA-4 CTLA-4 inhibitors rather in metastatic renal cell carcinoma.
Whether one will be better than the other?
Yes.
Yeah, I think we don't have enough data yet in RCC to know. And I think we're getting more data with the Merck compound and hopefully the Genentech compound coming up. There's also other ones from Amplimmune and MetaImmune, other drugs on the horizon. So I think that'll be a great if we can have that embarrassment of riches to be able to test that down the line.
And then lastly, what would you do for a clear cell T4 surgical treatment only in the past who now has a local recurrence, local resection only versus systemic followed by local resection if possible? I believe we have a clinical trial to address that.
We do. I was going to bring that up. So I think first of all, I would certainly consider, resection. No doubt there are certain series that have shown a survival benefit to metastectomy and including that in the resection bed. And Dr. Appelman and colleagues at the ECOG cooperative group have a trial actually looking at patients that have a metastectomy and randomizing them to pazopanib versus placebo. And so I think that's a really great option, that trial. I don't think that I would do it off trial. I wouldn't give the systemic therapy. I'd let the patient enjoy their life, go through surgery, and then treat only if they recur. But this might be a patient with more clinically indolent RCC that you can do metastectomy after metastectomy. There are a handful of those patients that we've all had.